Hello, everyone. So today let's discuss this new guideline on investigation and care of small for gestational age fetus and growth restricted fetus. So it's a very important guideline from examination point of view. And I've again tried to make it as simple as possible. So let's discuss the definitions first. What is appropriate for gestational age fetus, where the fetal size is between 10th and 90th centile? What about small for gestation age fetus, where the fetal size is less than 10th but more than 3rd centile? That is, fetal sizes between 3rd and 10th centile. What about fetal growth restriction? Here, fetal size or abdominal circumference is less than 3rd centile or less than 10th centile with evidence of placental dysfunction or Doppler abnormalities. So there can be abnormality in the uterine artery Doppler, where pulsatility index is more than 95th centile, and or abnormality in the umbilical artery Doppler with pulsatility index of more than 95th centile, or absent or reversed end diastolic flow. Okay, so small for gestation age is considered to be benign. Babies can be constitutionally small and normal without any abnormality, without any pathology. But fetal growth restriction, these fetuses they can be abnormal and there can be some underlying pathology. And for FGR, we have to assess the Doppler abnormalities as well. Now, FGR can further be divided into early FGR, which occur before 32 weeks, late FGR occurring from 32 weeks onwards. Then there is a definition in this guideline. What is a static growth? There is no forward growth velocity in abdominal circumference or estimated fetal weight measured at least 14 days apart. Now, how to define FGR in previous pregnancy? So this is the new in this guideline. And it is defined only if any of the following is present: birth weight less than 3rd centile in previous pregnancy, early onset preeclampsia or FGR necessitating birth at less than 34 week in previous pregnancy, or birth weight is less than 10th centile with evidence of placental dysfunction, that is where there are Doppler abnormalities. Okay, so in the current pregnancy, this will be the definition of fetal growth restriction. That is, fetal size or abdominal circumference is less than 3rd centile or less than 10th centile with placental dysfunction or Doppler abnormalities. Now, coming to small fetuses, they can be normal, that is constitutionally small without any underlying pathology, or they can be non-placenta mediated growth restriction. So this can be because of structural or chromosomal anomaly, inborn errors of metabolism, or fetal infections. And another one can be because of placenta mediated growth restriction, that is, there can be placental dysfunction. So there are many factors which can affect the placental transfer of nutrients causing small fetuses, like maternal factors, like low pre-pregnancy weight, undernutrition, substance misuse, like opioids, and severe anemia. There can be maternal medical conditions which can affect the placental vasculature, like preeclampsia, autoimmune conditions, thrombophilias, mainly acquired thrombophilias, renal or cardiac disease, diabetes, essential hypertension. And all these factors, they can cause early FGR, that is before 32 weeks. So small fetuses can be divided into normal fetus, or they can occur because of non-placenta mediated growth restriction or placenta mediated growth restriction. Now, what about the risk reducing strategies? How to prevent small fetuses in general population? So first, very important modifiable factor is advising the woman to stop smoking. So for this, women are identified who smoke with the carbon monoxide testing. And they are ensured in-house treatment by a trained tobacco dependence advisor. And women, they have the right to opt out of this service. Smoking can be replaced by e-cigarettes or nicotine replacement therapy by experts. And they should be advised that if they are able to quit smoking by 15 weeks of gestation, the pregnancy risk is similar to non-smoking women. What about the medications? We know vitamin D 10 microgram throughout pregnancy and folic acid 400 microgram pre-conception and up to 3 months of pregnancy is very important for the woman to take. What about risk reducing strategies in women at risk of fetal growth disorders like SGA or FGR babies because of preeclampsia and placental dysfunction? So in these women, we will offer aspirin 150 milligram once daily, preferably at night from 12 weeks to 36 plus 6 weeks. So aspirin is ideally started before 16 weeks by 12 weeks. And risk assessment for small babies, that is for FGA and FGR, is done at booking, that is at least by 14 weeks, and at mid-trimester anomaly scan. And then accordingly, women are classified into low risk, moderate risk, and high risk of having small babies. Now, what about the surveillance after risk assessment? So we have to see if the woman is at low risk or she's not having risk factors. So we will be like risk assessment is done at booking at 14 weeks. Then we ask the woman to come routinely at 20 weeks for the mid-trimester anomaly scan. And here we also check the estimated fetal weight. And if it is more than 10 centile, women is offered only measurement of the symphyseal fundal height in singleton pregnancy, and this is the routine surveillance. And regarding the FSH measurement, it is offered every 2 weeks, no more frequently than every 2 weeks. And FSH is offered after 24 weeks, and first measurement should be carried out by at least 28 plus 6 weeks. Now, if there is SGA or LGA baby diagnosed with the help of SFH, then women is offered further ultrasound scan for fetal growth and well-being. And routine ultrasound scan is not offered after 28 weeks in any uncomplicated pregnancy. Okay, so this is from the Green Top guideline. We will assess the risk at booking and at mid-trimester anomaly scan if there is low risk and like there is no risk factors, so women are at low risk. We are doing the anomaly scan and estimated fetal weight is 10th or more centile, then women is only offered SFH. Okay, serial measurement is done with the SFH. How to do surveillance in moderate risk factors. So here we have to take the history from the women, inquire about her previous obstetric history, and if she has previous SGA baby, previous stillbirth where the baby was appropriate for gestation age, and current risk factors when we are asking about the social history, smoking, any drug misuse, women, elderly women, 40 years or more of age at booking, BMI is less than 18.5, and if she is having other features like eating disorder, bowel disorder causing weight loss, if she is having gastric bypass surgery, okay, and previous preterm birth, second trimester miscarriage, which was placenta mediated, then we have to prescribe aspirin if history is suggestive of placental dysfunction. And all women on the moderate risk pathway, they will need one of symphyseal fundal height measurement at 28 weeks. And then ultrasound scan from 32 weeks onwards every 4 weeks until delivery. Okay, so This is for the moderate risk factors. They will need symphyseal frontal height measurement at 28 weeks, and from 32 weeks onwards, serial scan every 4 weeks until delivery. And we will also consider prescribing aspirin in these women. Now, coming to management and surveillance of women with high risk factors. So again, in the medical history, we have to inquire about the maternal medical conditions like chronic kidney disease, hypertension, autoimmune disease. These are SLE, antiphospholipid syndrome, complex cardiac disease. Obs history, important history will be previous FGR. So in the moderate risk factor, it was previous SGA. Here, if it is previous FGR, then this is the high risk factors. Hypertensive disease in a previous pregnancy, previous SGA stillbirth. And in the current pregnancy, if biochemical tests are done and Down syndrome screening testing is done and PAPA is less than 5th centile, inhibin A is more than 2, multiples of median AFP is more than 2, there is echogenic bowel diagnosed on ultrasound scan, that is at the mid anomaly scan, and if woman has significant bleeding, estimated fetal weight is less than 10th centile, there is single umbilical artery, then these women are at high risk of developing small babies. So we have to consider prescribing aspirin 150 milligram from 12 weeks onwards, that is at least before 16 weeks as appropriate. And more so in women with previous hypertensive disease, previous FGR, where centile was less than 3rd centile, or the fetal size was less than 10th centile, and baby was born at less than 34 weeks. So these are all indicators of placental dysfunction. So we have to offer aspirin. Now, what about the further monitoring? So we know that uterine artery Doppler is done at the time of the mid-trimester anomaly scan. So we will see if uterine artery Doppler and estimated fetal weight is normal, that is more than 10 centile, then serial scan is done from 32 weeks, every 2 to 4 weeks until delivery. Uterine artery Doppler is normal, but estimated fetal weight is less than 10 centile. Then ultrasound scan is done from 26 to 28 weeks until delivery, and this will be individualized. If uterine artery Doppler is abnormal, estimated fetal weight is 10th or more centile, then the serial scan is done from 28 weeks, 2 to 4 weekly until delivery. If both are abnormal, that is uterine artery Doppler is abnormal and AC or estimated fetal weight is less than 10 centile, it means that there is something very serious going on and there can be some serious underlying pathology. So we have to discuss with the fetal medicine specialist. Okay. Now, how to monitor the women who are unsuitable for monitoring by symphyseal fundal height measurement. Like we know women whose BMI is 35 or more, who are having fibroids, or those with congenital uterine anomalies. So in these women, scan is offered from 28 weeks with congenital uterine anomalies, and from 32 weeks in women unsuitable for SFH, and scan is done every 4 weeks. So from 32 weeks, it will be for women with BMI 35 or more and fibroids. And scan from 38 weeks will be those in women with congenital uterine anomalies. All right. What about the further assessment? So we are doing the assessment at booking, then at mid-trimester anomaly scan, and again, reassessment is done at the 28 weeks appointment and after any antenatal admission. So we have to assess for complications developing in pregnancy, like hypertensive disorders or significant bleeding. And if these complications are present, then we will offer serial ultrasound scan from diagnosis until delivery. Now, how are we going to do the surveillance once the diagnosis is made, and what about the timing of delivery? So surveillance in SGA fetuses is done by estimated fetal weight fortnightly, that is every 2 weeks, and umbilical artery Doppler also fortnightly every 2 weeks. So in SGA, estimated fetal weight and umbilical artery Doppler, they both are done every 2 weeks. And in FGR babies, estimated fetal weight is done every 2 weeks, but umbilical artery Doppler is done weekly. Because FGR babies, they will need more frequent surveillance. That is why umbilical artery Doppler is done weekly. What about timing of delivery in SGA babies? So here we know surveillance is done with the estimated fetal weight and umbilical artery Doppler every 2 weeks. And we have to exclude FGR. Once FGR is excluded and we know that the baby is only small for gestation age, then birth or initiation of induction of labor is considered at 39 weeks, and birth should occur by 39 plus 6 weeks. So in SGA babies, birth should occur by 39 plus 6 weeks. If SGA baby is more than 37 weeks, then there are some other monitoring modalities like middle cerebral artery, cerebroplacental ratio, or UCR, that is umbilicocerebral ratio, is considered, and they are used to guide the timing of delivery. But still, the guideline says that even if these are normal, MCA, CPR, UCR is normal, and baby is SGA, then still we will deliver by 39 plus 6 weeks. That is, we are not going to go beyond 40 weeks. By 39 plus 6 weeks, these SGA babies should be delivered. Now, surveillance and timing of delivery in FGR babies. So here we have to do the monitoring with the umbilical artery Doppler and ductus venous Doppler accordingly. So if umbilical artery Doppler is normal or borderline, meaning pulsatility index is more than 90th centile, then we will repeat the scans, that is umbilical artery Doppler and ductus venous Doppler and the CTG every week. But if it is pre-critical, that is the umbilical artery Doppler has absent end-diastolic flow, then we will be repeating the ultrasound scans, that is umbilical artery Doppler scan and ductus venous Doppler and CTG on alternate days. If it is critical, now critical is something very dangerous. That is where there is reversed end-diastolic flow, then we will be repeating all the scans, the umbilical artery Doppler, ductus venous Doppler, and CCTG, that is the computerized CTG, and or ductus venous Doppler daily. Okay, so where umbilical artery Doppler is normal or borderline, monitoring is done every week, that is weekly. If it is pre-critical, monitoring is done on alternate days or at least twice weekly. And critical, then monitoring is done daily. Then what about ductus venous Doppler? It is borderline if there is raised pulsatility index velocity of more than 95th centile. It is pre-critical if there is absent A wave. It is critical if there is reversed A wave. Okay. How to manage early FGR, that is up to 32 weeks. So in these early FGR babies, we have to take input from tertiary level units with highest level neonatal care. So MDT input is very, very important. Monitoring is, any FGR monitoring is by estimated fetal weight fortnightly and umbilical artery Doppler weekly. If any time there is absent or reversed end-diastolic flow in the umbilical artery Doppler, then monitoring is done twice weekly with CCTG, and in CCTG we will see the variation, that is this is STV is very pathognomonic of fetal hypoxia. These are the small term variations. These are also like the beat to beat variability which we see in the normal conventional CTG. But beat to beat variability is like it is beats per minute. But STV, the short term variation is every milliseconds we are monitoring. And also we can use the ductus venous Doppler. Okay. Now, how about the monitoring and delivery? So in early FGR up to 32 weeks, if the baby is between 24 to 26 weeks, there has to be individualized care plan. So we have to take the input from the highest level unitologists. The tertiary level units we have to coordinate with them. Then if the gestation age is between 26 to less than 29 weeks, then we have to deliver. If ductus venous A wave is absent or reversed, or the STV in the computerized CTG is less than 2.6 millisecond. If gestation age is between 29 to less than 32 weeks, then we have to deliver if ductus venous A wave is absent or reversed, or STV is less than 3 millisecond. Now, this is important that if any time there is reversed and diastolic flow, then we have to deliver by 32 weeks, consider delivery from 30 weeks. If any time there is absent and diastolic flow, so we can wait for a while. Delivery can be by 34 weeks, but we should consider delivery from 32 weeks. Okay. Also, if umbilical vein Doppler shows abnormal and there are some abnormality with pulsations, that is, it shows abnormalities with pulsations, then we have to assess the ductus venous waveform. Anytime the woman is complaining of reduced fetal movement, then computerized CTG is done to monitor the fetal heart rate. Now let's discuss the management of late FGR. So in any FGR, we know monitoring is by estimated fetal weight fortnightly and umbilical artery Doppler weekly. If gestation age is between 32 to less than 34 weeks and there is absent end-diastolic flow, then monitoring is done minimum twice weekly with CTG and or ductus venous. If there is reversed end-diastolic flow or absent A wave, then we have to deliver. And we will deliver also if CTG STV is less than 3.5 millisecond. Now, in gestation age, between 34 to less than 37 weeks, if umbilical artery Doppler pulsatility index is more than 95th centile, then we have to monitor twice weekly with CTG. Okay. Then, when are we going to deliver? If STV is less than 4.5 millisecond, or there is absent end-diastolic flow. And also we have to deliver by 36 to 36 plus 6 weeks if umbilical artery pulsatility index is more than 95th centile. Again, if reduced fetal movement anytime, we will offer the computerized CTG. Now, in all FGR cases, we will deliver if spontaneous, repeated, unprovoked deceleration is present on CTG and or maternal indications like bleeding or high blood pressure is there. Birth should be initiated from 37 weeks and completed by 37 plus 6 weeks. So in all FGR cases, we have to deliver by 37 plus 6 weeks. Whereas in all SGA cases, we should deliver by 39 plus 6 weeks. All right, now coming to FGR at term 37 weeks onwards, then what we will be doing, again, monitoring is by estimated fetal weight fortnightly and umbilical artery Doppler weekly. So at gestation age between 37 to less than 39 weeks, we will deliver if AC or estimated fetal weight is less than third centile by 37 plus 6 weeks. And if FGR cannot be excluded, then we have to discuss the management. Now, what about the MCA Doppler and cerebroplacental ratio? If they show any signs of cerebral redistribution or Doppler abnormalities, then we have to deliver. So between 37 to less than 39 weeks, we will see if AC or estimated fetal weight is less than third centile, then we have to deliver the baby by 37 plus 6. Okay. What about gestation age at more than 39 weeks? We will deliver if SGA. If only SGA, then we can wait and deliver by 39 plus 6 weeks. Now, the guideline says that MCA and CPR, that is cerebroplacental ratio, less than fifth centile, should determine the frequency of surveillance with umbilical artery Doppler and CTG. So this will be again done by the experts. Then medications are important. Corticosteroids for fetal lung maturation. It is offered between 24 to 34 plus 6 weeks, ideally 48 hours before an anticipated birth. Magnesium sulfate is given for fetal neuroprotection. It is offered between 24 to 29 plus 6 weeks, considered up to 33 plus 6 weeks. Now, what about the delivery? So, delivery by cesarean section, there are some indications, and since babies are delivered preterm, so we will be offering corticosteroids and magnesium sulfate. So, for cesarean section, there are some indications like if there is abnormal CTG, STV, or there is ductus venous alteration. Umbilical artery is showing absent or reversed end-diastolic flow, then baby has to be delivered by cesarean section. Okay. Indications for induction of labor. So when we are offering induction of labor, we should consider mechanical methods. And there has to be continuous fetal heart rate monitoring, and there is also more risk of emergency cesarean section. So women having SGA baby and there is late FGR with normal umbilical artery Doppler or abnormal umbilical artery Doppler pulsatility index, but end diastolic volume or end diastolic flow is present, then we can offer delivery with induction of labor. Now, there are some important points which we should remember that fetal size alone is not sufficient to identify FGR unless AC, abdominal circumference, or estimated fetal weight is below the third centile. So FGR, we know that AC or EFW is less than third centile, or if it is less than 10th centile, but with placental dysfunction or Doppler abnormalities. Fetal growth disorders are suspected when there is suboptimal reduced growth velocity and static growth. Then FGR can also be diagnosed when there is a drop of more than 50 centiles in estimated fetal weight or abdominal circumference. And this should prompt a full review. So whenever women is coming at their antenatal appointments, and when we see the graph and there is fall of more than 50 centiles in EFW or AC, then this is also an indicator of FGR. Doppler velocimetry of uteroplacental circulation may be used to help distinguish between SGA and FGR in the third trimester. So Doppler velocimetry means that In SGA, usually there won't be any Doppler abnormalities, but in FGR, there will be Doppler abnormalities like we discussed earlier. When a fetal growth disorder is diagnosed, an assessment of fetal well-being should be made. So we have to inquire about fetal movements and offer the woman computerized CTG if there is any concern. Maternal assessment is done by checking the blood pressure and urine for protein. Now, when are we going to refer the woman to fetal medicine unit? If estimated fetal weight is less than third centile or less than 10th centile, with abnormal uterine artery Doppler at the mid-trimester anomaly scan. Now, invasive diagnostic testing should be offered in severely SGA fetus with structural abnormalities and considered in non-anomalous fetuses detected before 23 weeks of gestation, especially if uterine artery Doppler is normal. So this is about the invasive diagnostic testing where we have severe SGA fetus with structural abnormalities. And if there is a fetus which is severe SGA and there is no structural abnormalities before 23 weeks of gestation, and uterine artery Doppler is normal, then antenatal serological screening is done for infections like for CMV and toxo in severe SGA, and malaria and Zika virus in high-risk population because these infections can cause SGA babies. What about postnatal investigations and pre-pregnancy counseling? So we will be offering histopathological examination of placenta where FGR is diagnosed prenatally or at birth. Why? To understand the underlying cause and guide management in a subsequent pregnancy. Because we know FGR in current pregnancy is a very high risk factor, that is severe risk factors, high risk factor for FGR in the next pregnancy. Now, we also will offer appointment for postnatal counseling, review of placental histology, and consider investigations to find out the underlying cause of FGR. Like we can offer investigations for acquired thrombophilias like antiphospholipid syndrome. Also, we will discuss the plan for future pregnancies and preventative strategies. Like there are some modifiable risk factors, like if the woman is a smoker, we will advise her for smoking cessation. BMI is high, then we can offer her BMI reduction and aspirin treatment. And the discussion should be recorded in the case notes. And also, we will make sure that we have discussed about the preventative strategies if she gets pregnant next time. And we have to emphasize the importance of the pre-pregnancy counseling in these women who had previous SGA or FGR babies. Thank you. I hope this was useful, and happy studying and all the best for your exams. Okay, thank you. Take care. Goodbye.